Hello and welcome everyone. Today's topic is severe dengue in ICU. The virus. The dengue virus is part of the flavivirus genus with Flaviviridae family comprising four primary serotypes, 1 to 4, affecting humans, and a fifth, V5, identified in the sylvatic cycle. The virus genome is a single-stranded RNA encoding 10 proteins, 3 structural MEC critical for the virus structure and 7 non-structural, that is NS1, 2A, 2B, 3, 4A, 4B and 5. This is essential for the RNA replication. The mature virion is characterized by a isocohedral shell with a lipid bilayer incorporating M and E proteins surrounding a nucleocapsid core of C protein encompassing the RNA genome. This structure facilitates the virus entry and replication within the host cell. The next is the infection. Now, the dengue transmission occurs when an infected female Aedes species mosquito bites a human, introducing the virus into the skin and subsequently the bloodstream, targeting various immune cells, mainly the macrophages, dendritic cells, and the Langerhans cells. Now, these infected cells migrate to the lymph nodes, spreading the infection and leading to a viremia. The intrinsic incubation period ranges from 3 to 10 days, with the E protein playing a crucial role in virus entry into the host cell by facilitating membrane fusion. The virus replication involves the translation of its RNA into the polypeptide, which is then cleaved into functional units, initiating a series of reactions that lead to an inflammatory response marked by release of cytokines. The dengue infection progresses through distinct phases: an initial febrile phase characterized by high fever and inflammation, followed by a critical phase marked by intravascular permeability which is increased, concluding with a convalescent phase as the patient recovers. So this is the pathophysiology of how it occurs. Here you can see the mosquito injects the virus, which are getting attracted to the inflammatory cells such as macrophages, Langerhans cells, which are then taking them to the lymph nodes where the inflammatory process is aggravating. It aggravates in basically two directions. One is the involvement of the glycocalyx layer and the endothelial inflammation, which results in the plasma leakage. The second is the effect on the platelets, thereby attacking the platelets and causing immune effect, thereby making the patient more vulnerable to hemorrhagic complications. Apart from that, it can also affect the bone marrow, thereby reducing the production of platelets as well. So it has got two very distinct reactions. One is the plasma leakage, the other being the hemorrhagic complications. So what are the mechanism of severe infection? First is the cytokine storm. The antibody dependent enhancement is identified as a pivotal factor in severe dengue infection, whereby secondary infection by different serotypes lead to enhanced viral entry and replication due to formation of virus antibody complex. This is facilitated by a non-neutralizing heterotropic antibody from previous infection or vaccination, increasing the virus's ability to infect the host cells. The cytokine storm results from a substantial virus load that triggers a robust immune response, activating inflammatory cascade. This includes a weak cross reaction of the T cell to the new serotype, leading to an overproduction of pro-inflammatory cytokines and further exacerbating by the NS1 protein. This cascade of event results in excessive inflammation and tissue damage. Next is vascular permeability. The dengue vascular permeability syndrome, integral to severe dengue manifestation, involves complex interaction leading to increased capillary permeability and plasma leakage. Direct infection of the endothelial cells, cytokine induced damage, and immune mediated mechanism contribute to the process. The NS1 protein again plays a significant role in disrupting the endothelial barrier, potentially through interactions that lead to endothelial cell dysfunction and plasma leakage. Platelet activation and the release of inflammatory mediators further exacerbate vascular permeability, contributing to the severity of the dengue infection. Thrombocytopenia and coagulopathy. Thrombocytopenia in dengue fever stems from multiple factors like direct suppression of the bone marrow, antibody-mediated lysis of the platelet, increased consumption due to endothelial damage. The infection impacts the megakaryocytes and hematopoietic stem cells, affecting the production and as well as the function. Alteration in the coagulation and the fibrinolysis pathways include prolonged clotting times, imbalance in fibrinolytic mechanisms, characterized coagulopathy in dengue fever. These changes, coupled with liver damage and activation of the coagulation factor, contribute to the complexity of the managing severe dengue. Now, what are the factors which are associated with severe dengue? The first is the immune status of the patient. The severity of the dengue fever is significantly influenced by the immune status of the individual. Antibody dependent enhancement is a key factor, especially during a secondary infection with a different serotype, leading to more severe disease outcome due to the increased viral entry and replication. Now, the interval between infections play a critical role, with longer intervals potentially increasing the severity of the disease. This attributes to the decline in circulating neutralizing antibody over the time. Now, infant born to dengue immune mothers and individuals vaccinated with the vaccine without prior dengue infection are at increased risk of ADE. The WHO recommends the vaccine only for seropositive individuals. Now, previous exposure to Zika virus, another flavivirus, may predispose individual to a more severe dengue infection due to cross-reactive antibodies, underscoring the complex interplay between flavivirus and the immune response. The next is the virus strain. The biological and the phylogenetic distinction between the four dengue serotypes and the respective genotype influence the disease transmission and severity. Variation up to 30% in the polyproteins among the serotypes suggest significant difference in the virulence and transmission efficacy. Certain strains, like the Asian strain of the version 2, have shown higher propensity to cause severe disease, highlighting the impact of viral genetics on the disease outcome. Next is the genetic status. Host genetic factors include variation in the HLA alleles and other specific genes, which play a crucial role in determining the severity of the dengue infection. Individuals with certain genetic background are more susceptible to severe forms of the disease. Now, genetic predisposition highlights the importance of understanding individual risk factors in management and prevention of severe dengue. The next is host factors. The age and underlying health conditions significantly affect the risk of developing severe dengue. Infant and older adults are particularly vulnerable due to increased susceptibility to vascular permeability and presence of chronic conditions. Chronic disease such as diabetes, hypertension, cardiovascular disease, renal disease, and asthma increase the risk of severe dengue, as does obesity, which contributes to a pro-inflammatory state. Sex has been identified as an independent risk factor, with female sex showing higher risk of developing severe dengue and experiencing high mortality rates. Although the reasons why this can happen is not fully understood. Now, here is a summary of all the factors. First is the host factor that we have seen here as the age, the female sex, pregnancy, immunocompromised patients, patients with comorbidities. The immune status, that is previous infections, timing between the two infections, and previous exposure to other flaviviridae. The virus strain can also affect. Finally, the genetic status of the patient can also affect the disease severity. So, what are the clinical features of dengue? First is the clinical lab manifestations. Dengue presents as a broad clinical spectrum, with 70 to 85% of the infections being asymptomatic, while 5% evolve into a severe disease. The illness progresses through three phases: the febrile, critical, and the recovery phase. Now, the febrile phase. The symptoms are high fever, headache, myalgia, arthralgia, retroorbital pain, often accompanied by GI symptoms, particularly in children. Leukopenia and thrombocytopenia may occur alongside skin manifestations like petechiae and ecchymosis. Next is a critical phase. This is increased vascular permeability leading to plasma leakage, hemoconcentration, and a drop in platelet count. Patients at this stage are at risk of developing shock, hemorrhage, and organ impairment. Characterized by resorption of the extravascular fluids, improvement in the clinical status, and normalization of the leukocyte and platelet levels, some patients may experience prolonged symptoms post recovery influenced by their immunological state and genetic factors. The next is the warning signs and the severity classification. In 2009, WHO advised the classification of dengue focusing on the identification of warning signs to predict severe disease outcome. The new classification distinguishes between dengue with or without warning signs and severe dengue, aiming for more accurate patient assessment and timely intervention. The warning signs are abdominal pain, persistent vomiting, rapid breathing, bleeding, fatigue, restlessness, and liver enlargement. If any of these signs are present, then it is critical for early detection and potential progression into severe disease. Now, severe dengue is defined by severe plasma leakage leading to shock, significant bleeding, and severe organ involvement. The identification of severe dengue is crucial for prompt referral to ICUs to manage life-threatening complications effectively. This is the summarization of the dengue classification, where you have the dengue fever, which is basically fever with nausea, vomiting, rash, and pains. You can have leukopenia and no warning signs. While if you have warning signs like the abdominal pain, persistent vomiting, fluid accumulation, mucosal bleed, lethargy, liver enlargement, and certain lab parameters, then this patient should be immediately referred to a hospital. While severe dengue is severe plasma leakage or severe bleeding or severe organ involvement like liver, AST/ALT more than 1000, impaired consciousness, and shock. If any of these severe dengue features are present, then the patient must be immediately sent to an intensive care unit. Now, what is the diagnostic approach? There are some specific diagnostic tests which are phase dependent. That is, the febrile phase is the first 5 days, focusing on the virus or antigen detection. The later rely on the antibody detection. The early phase is NS1 antigen detection through the ELISA and rapid immunochromatic tests, which is simple, low cost, and high specificity. The sensitivity varies but generally remains effective up to the ninth day. Now, nucleic acid amplification techniques like RT-PCR can detect the RNA, and therefore high sensitivity and specificity. However, they are not very simple and they are logistically challenging, so not widely used. The next is serological tests, which is after 5 days, where you detect the IgM and IgG. And IgM is detected as early as 4 days, and secondary infection can show a rapid rise in the IgG with IgM levels as a potentially undetectable. Now, the next is challenges in the differential diagnosis. In regions with multiple circulating flaviviridae like Zika and chikungunya, the differential diagnosis becomes challenging due to similarity of the symptoms, cross-reactivity, and in this case, RT-PCR is recommended. Virus isolation is highly specific but rarely used outside research settings. Now, complementary diagnostic tests that are available are routine lab tests like full blood count recommended for suspect and confirmed cases with monitoring of the leukopenia and thrombocytopenia. Additional tests like LFT, potentially severe disease progression markers like creatine kinase for myositis are advised. Point of care ultrasound can be invaluable in early detection of plasma leakage, including pleural effusions, ascites, which is crucial in managing severe cases. So as you can see here, the three phases are febrile, critical, and convalescent. The leukocyte count, as you can see, gradually declines over the later part of the febrile phase and is the lowest during the critical phase. Similarly, the plasma leakage heightens in the critical phase with hematocrit values increasing in the critical phase, and platelet values again similarly going down in the critical phase. So the first infection, the viremia, is seen in the febrile period with NS1 antigen detection. IgM comes later on, IgG during the convalescent stage. However, if it is a second infection, the NS1 uh, goes out early. You get IgM also quite early and IgG also quite early, as early as day 2. So the next is organ dysfunction. The first is hydration overload. Fluid management becomes a critical part during the recovery phase of the dengue fever due to rapid resorption of fluid from the virtual spaces. Incorrect fluid management, including excessive and inappropriate fluid administration, can lead to hydration overload, resulting in complications such as pulmonary edema and congestive heart failure. High risk patients with pre existing conditions like heart failure, lung disease, and renal dysfunction should be very well managed in terms of the fluid. In case of hypervolemia with respiratory distress, diuretics should be used, but underlying causes such as ocal bleeding and cardiac impairment must be considered in these cases as well. The next is the bacterial co-infection. Though relatively rare, it is still seen and it is associated with increased morbidity and mortality. The common infections are pneumonia, bacteremia, bile duct infection, urinary tract infections. The risk factors are old patients, AKI patients, GI bleed patients, prolonged fever, altered sensorium. The diagnosis is complicated by the overlapping symptoms, but if the patient is old age, you must keep in mind these factors. Prompt initiation of antibiotics is crucial in this case. The next is neurological impairment. It is a neurotropic capability. It has various neurological manifestations, the most common being the encephalopathy and encephalitis. Encephalopathy is characterized by altered sensorium, cognitive impairment, and seizure. And normal CSF finding with possible neuroimaging finding is very characteristic of dengue infection. Encephalitis presents with similar symptoms but shows slight alteration in CSF, uh, lymphocyte pleocytosis, and hypertense foci on the CT indicating of microhemorrhages, with MRI revealing some specific brain stem lesions. The next is immune mediated symptoms like GBS, ADEM, which can also be seen in this case. They can be treated with IVIG and corticosteroids. Muscle dysfunction and neuroophthalmic disorders can be seen in some cases of dengue. The next is hepatic. The dengue virus infects the hepatocytes and Kupffer cells, leading to liver damage manifested by AST and ALT elevation, which is a marker of severe disease. Pathogenesis is direct viral effect, immune-mediated damage, and apoptosis of the liver cells, cytokine release, and contribution to the liver dysfunction. ADE and constitutive activity may exacerbate the liver injury. Significant liver damage can lead to hepatic dysfunction and failure, emphasizing the need for careful monitoring and managing these patients. The next is cardiac. Cardiac involvement is seen as mild ECG changes with which is indicating myocarditis leading to dyspnea, chest pain, and sudden death. Myocarditis relies on advanced imaging and biopsy findings, and pericardial effusion is one of the very important findings, with various ECG changes can be seen in these patients. Critical phase of dengue may present with bradyarrhythmias and hypovolemias, and which should be addressed appropriately. The next is kidney involvement. Kidney involvement in dengue ranges from mild abnormalities such as electrolyte imbalance and proteinuria to severe conditions like AKI and hemolytic uremic syndrome. The proposed mechanism is the hypotension leading to hypoperfusion and tubular necrosis, direct viral injury, immune-mediated injury, and rhabdomyolysis. The immune histochemistry has shown that a combination of high viral load exacerbated by immune response and increased permeability result in the renal damage. Patient with chronic liver disease, transplant patient face additional challenges and they are at increased risk. The management includes careful fluid management, potential use of RRT, and continuous hemodialysis for patients in shock. The next is lung impairment. Pulmonary complications are very common, like ARDS and hemorrhage. These conditions result primarily from increased vascular permeability, plasma leakage, coagulation disturbances. Now, diagnostic tools like chest X-ray and lung ultrasound are essential in finding out these. Management focuses on, again, the fluid control, and some cases the potential use of corticosteroids and immunoglobulins can be done. Next is hematological. In hematological, you will see HLH and thrombocytopenia. Persistent thrombocytopenia after recovery, possibly due to immune-mediated destruction, is treated successfully with steroids and IVIG. HLH is a hyperinflammatory state triggered by excessive immune activation, presents as a diagnostic challenge because of lot of symptoms are overlapping. It is suspected in prolonged fever, thrombocytopenia, and hyperfibrinemia. Now, treatment is based on guidelines of the secondary HLH, which is steroids with primary and IVIG as an adjunctive therapy. The next is how to manage dengue. So to manage dengue, the general management is supportive care, early recognition of the warning signs, education to find out these warning signs. Antipyretics are more important because the fever and pain is very important symptoms. Steroids initially can be considered as in severe cases. Recent studies and a Cochrane review have not supported use, and it finds no significant benefit in reducing the severity of disease as of now. The next is the use of plasma leakage. Plasma leakage leads to shock, which is resulting in severe dengue. Volume resuscitation is vital in mild cases by oral and in severe cases by intravenous. WHO recommends the initial fluid expansion with crystalloids, reserving colloids for intractable shocks. Management should focus on improving circulation, monitoring clinical parameters, and hematocrit measurements. Vigilant observation in the first 24 to 48 hours is vital, and gradual weaning of the IV fluids is very important. The next is the management of thrombocytopenia. Bleeding is a common complication. Studies have shown a weak correlation between thrombocytopenia and the severity of bleeding, emphasizing the importance of managing shock during mitigation of the hemorrhagic shock. Prophylactic platelet transfusion. Current evidence do not really support the use of a prophylactic platelet transfusion. The risk of TRALI and the risk of significant benefit of from this is main factor in not allowing prophylactic platelet transfusions. Transfusion for significant bleeding. There is no RCT to evaluate a platelet transfusion being helpful in severe bleeding, but WHO recommends fresh RBCs for significant hemorrhage. Platelet transfusion may be considered in persistent and severe bleeding cases. Now the next part is the special population like older age. Atypical presentation in elderly patients, they present with atypical symptoms because of the immunosenescence, higher likelihood of secondary infections, and the chronic underlying conditions. So careful fluid management is crucial because the renal and cardiac impairment is common in these patients. Monitoring for complications. Consider anoseptic support early. These patients need higher ICU rates and longer hospital stay with increased mortality risk. The other special population is pregnant women. In this, there is an elevated risk of severe dengue, complicated to, to diagnose this in this patient group. Pregnant patients have higher risk of severe outcomes, and management consideration in these patients. Hospital admission is crucial if the term is full. Managing the fluid balance is vital to avoid overload. Delivery decisions should be done in taking into account both the mother and the fetus health with platelet transfusion. The next is other conditions like hypertensive patients. You must keep in account the hypertension level, the baseline blood pressures, so that you can detect the hypertension early. Diabetic patients, they are more likely to develop ketoacidotic and hyperosmolar comas. And the next is patients who are already on anticoagulants and antiplatelets. They are increased risk of bleeding. Patient on statins, there is some immunomodulatory effect. The clinical benefit is unproven and the use during the infection is debated. So patient on statins should continue to be on statin, but to use statin to prevent complications of dengue is not really supported as of now. Now, future perspective, antiviral development. It is still in early phases to find antivirals for dengue. The next is vaccine development. The availability of the tetravalent dengue vaccine has not shown to change outcomes, and the limitation is to be used among seropositive patients only as of now. So to summarize, first, find out if the patient is having any warning sign. Then you look for the features of severe dengue, that is severe plasma leakage, severe bleeding, or severe organ impairment. If you find any one of these, then admit the patient into the ICU. The next you have to look for is whether the patient has a compensated or a decompensated shock. If the patient is having a decompensated shock, then start fluid immediately and monitor the hematocrit levels. If the patient is in compensated shock, then you start just fluid and give a fluid bolus and then check how the fluid status of the patient is changing. Now, once you've started the patient on fluids in a shock case, then you must look for if there is signs of improvement. That is, you must find improvement in the vital signs, the pulse volume, the capillary refill time, and the temperature of the extremities. So please note, these things must be noted prior to your resuscitation so that post the resuscitation you can check whether there is an improvement or not. Now, if there is no improvement, then obtain a new hematocrit level. If the hematocrit level is increasing, then there is more plasma leakage, then you have to give more fluids. If there is a decrease in the hematocrit level, then check for overt bleeding signs. If there is bleeding, then transfuse. If there is no bleeding, then continue giving the fluids. Regarding the patients who are on the compensated part, if they are showing improvement, then they must be continued as it is, and if they are not, then you have to look similarly as over here, looking at the hematocrit level. So basically, warning sign: find out severe dengue, check out if the patient is in shock, give fluids, check your hematocrits, check the vitals after the fluid. If the patient is showing improvement, then continue on the same lines, gradually decrease the fluids and wean them after 48 hours. If the patient is showing no improvement in terms of the shock, then check the hematocrit. From the hematocrit is increasing, then there is a plasma leakage, give fluids. If the hematocrit is not increasing, then there is a chance of bleeding. If there is a bleeding, then transfuse. If there is no bleeding, then give fluids. So as of now, this is only the treatment. We are just dealing with the symptomatic management. We don't have any specific treatment for dengue as of now. So thank you for your patience.